Good afternoon, ladies and gentlemen. I know postprandial is a bad time, but we do intend to get your attention very soon because we have a very illustrious panel of speakers. I feel very honored to be asked to chair this session, which is usually considered the showpiece or the centerpiece of the conference, that is the CEO's panel. The subject that has been chosen this time is a little offbeat from the management perspective, but is a very routine thing in surgical conferences. In surgical conferences, we have sessions called How I Did It, in which a leading surgeon usually tells how he performs a particular surgery. The idea came from that why can't we inculcate some of the learnings which these organizations in their different fields are doing so that everyone can learn from one another and everyone in the audience can learn from them as to why this is important from the healthcare delivery perspective. We all know medicine is a complex system. When I last counted, there were over 13,700 diagnoses, over 4,000 procedures that were done. And if you discount India, internationally, there are about 6,000 drug combinations and drugs available. The medical person is supposed to remember everything. Unlike the lawyer or the architect, he can't refer to a book. Because if you are a patient and your doctor starts referring to a book to find out what your diagnosis is, you will walk out. So it's one of the most complex delivery systems, and therefore it was Professor Clay Christensen of the Harvard Business School who opined that an industry that has not been healthcare is an industry that has not been designed to help health providers work better. And the reason is very simple, because it's complex, it's an ever-moving part, because medicine as yet is only partly understood. Therefore, it's both a science and an art. Unfortunately, a human being is the only model that comes to this earth without a circuit diagram. And therefore, it is impossible to find out how to correct the faults. And therefore, the industry has so many moving parts and so many moving issues on a daily basis that no other industry equals it as far as the challenges in this particular industry are concerned. The other problem is self-created by this industry, and that is that instead of considering the other hospital chain as a competitor or a rival, we sometimes consider him to be an enemy. And therefore, health is one area, or healthcare industry is one area where collaborative work is very rare. Healthcare does not seem to learn from other industries, and least of all, it does not seem to learn from the good work that its competitor may be doing. I'll give you an example. Healthcare in management circles is very often compared with airlines industry, and it's often said, why can't we copy what the airline management does and get better at what we do? One single example that is often quoted in management books would be how the airline industry overcame the problem of communication, which they thought was one of the reasons for air crashes. And everybody knows that the lack of communication is linked to airline disasters. The airline industry not only just knew it, but they acted on it, and they developed what is called the CRM, the crew resource management system. Like aviation, in healthcare too, mistakes are very common because of the reasons I have enumerated: the number of diagnoses, number of drugs, number of procedures, etc. But if the airline could reduce its errors by 70%, why couldn't the healthcare industry? A few years ago, an Air France flight 447, which was an Airbus. It crashed. And imagine what was said by Boeing, which is the primary competitor of Airbus. And I quote, "Boeing is looking at the crash report to see if there are any safety issues that could apply to Boeing aircraft. We strive to make our airplanes as safe as we can," and this is the key sentence, "we know that Airbus does as well." This is Boeing talking about its main competitor and learning, wanting to know what caused the Airbus crash so that they could prevent that in the aircraft that they were making. Now, this is a difficult thing to imagine in healthcare. And that is why I'm immensely grateful to these ladies and gentlemen who come from different parts of, or different facets of healthcare delivery, who agreed to come not only to share what they do best with each other, but also with you and with the healthcare industry in general. Ladies and gentlemen, please join me in applauding them, not just for their bravery in being together, but for the fact that they are doing some excellent work in healthcare delivery. I will begin by one other thing before I conclude my remarks, opening remarks, and that is that each one of them represents a different part of the healthcare delivery. While Rajit Mehta, who's the MD and CEO of Max Healthcare, will be talking about customer experience, a project LEAP that they do. Varun Sood, who's the CIO of Fortis Healthcare, will be talking about F1, a project which they're doing on HR service, HR supply management and finance. Usha, who's been here with us earlier, she comes from Arvind Netralaya. I don't need to introduce what this organization is all about. She'll be talking about how they're utilizing training paramedics to do a huge amount of work, cutting down on cost of care in a major way, and also keeping the community happy and involved. Anupam Sibal, Professor Anupam Sibal is somebody I'm immensely proud of, the Group Medical Director of Apollo. He's going to present a purely clinical picture, and that is the ACE 25 program of Apollo Hospital, which deals with the 25 parameters of good clinical quality governance. And then, of course, my old friend Harish, who's from Indus Healthcare, who will be talking about the stakeholder management program, because they are healthcare facilitators, an absolutely new concept which they brought into India, and that focuses on preventive and diagnostics. And when we talk of diagnostics, Philips can't be too far away. So Shrikant, who's to my extreme left, will be talking about EICUs as a means of healthcare delivery in a subject where subject matter experts are rare to find. So let me begin by asking Rajit Mehta, the MD and CEO of Max Healthcare, to talk about Project LEAP. He's not just the MD and CEO of the company, he also is a member of the board of directors of the company. He was a founder member of Max Life Insurance, and prior to that, he had a stint as director personnel at the Bank of America. He's a graduate in commerce and postgraduate in human resource development. Rajit.
Thank you. So as I was saying, Dr. Puri, thank you for organizing the session in the format you have chosen to. I'm sure it's going to be a good learning experience for us. And as the theme of this conference suggests, indeed it is time for us to shift paradigms in healthcare. Given the quantum of change that we're seeing come through, whether it's business models or patient expectations or the quantum of investment, I think it's time to relook some of the assumptions that we made many years ago. Some weeks from today, I was talking to Dr. Charles Denham in California. As you know, he's a great proponent of patient safety. And one of his associates is Clay Christensen, the person that Dr. Puri mentioned. And Clay talks about, he's a professor in Harvard, and he talks about hospital models. And he says that one of the core pillars of any hospital model is the value proposition to a patient. Now, once I heard that, I said it's quite counterintuitive. At the end of it, all of us serve patients who walk inside our door. So what's this value proposition? We're not an FMCG company. But therein lies this paradigm. Unless we're able to understand the nuances of what the patient expects in terms of value for money or expertise or care or convenience, it's very difficult for us to organize our people, processes, resources, technology, or infrastructure to be able to enhance patient experience. So Max started this journey, a few months back on trying to listen more intimately and more closely to what the patient required. And in fact, if you go back to the airlines industry, Indigo is a great example of an insight which they discovered. All of us for years were, suffering the issue of the planes not being on schedule. And there this one company took that insight and architected an entire business model around it. And the results are for all of us to see. So we started this journey about 6 months back, and we said, let's look at the unique insights that we get to know once we hear the patient's story. And here are a few of them. So if you look at discharge process, for example, all of us take it for a given. It takes time to get a patient discharged. But imagine that you're waiting. The doctor told you the previous evening before, or in the morning at 9:30, you'll get discharged, and you're waiting patiently, and it's about 2 o'clock. How would you feel as a patient? That's one pain point that we heard the patients tell us. The other one was on interdepartmental working. If you have to handle handoffs between pharmacy and nursing or billing or front office, and God help you if you have comorbid conditions, the coordination required by running pillar to post is humongous. Patient safety, Dr. Puri referred to that as well. I was looking at a research many, many years ago in the US where it was said that the chance of dying in an airplane is 1 in perhaps a million. And dying in a hospital because of infection is perhaps 1 in a few hundred. That's quite alarming. Of course, many years have passed and we have covered ground on that. But here are some of the pain points that we discovered. And we said, okay, how do we improve our listening process? So the old process really was that each time a patient would get discharged, you'll find a nurse walks across to the patient and says, please fill up this form. Now imagine if somebody is wanting to be discharged, waiting, and you have a nurse sitting on your head, and you try to tick the boxes. What responses will you get? In India, as a culture, we often don't give very adverse feedback that openly. So you'll find middle of the box ratings. So while we got good ratings, we were wondering whether this is the truth on the ground or not. So what we did, we said, let's change this process. So we went to IMRB and said, you're the specialist in consumer research. Tell us, how would you help us listen to the patients more intimately? So what do we do now? What we do is we call up about 1,000, 1,200, 1,400 OPD, IPD patients after discharge. There's a particular questionnaire we have designed. It takes about 6 to 8 minutes. And we listen to their voices. We also listen to calls. We also look at verbatims. And once we look at all this data, and by now, each unit can look at live data through a link every day of what customers are saying. So feedback on the process, sub-process, doctors, wait time, pharmacy, everything is available now for us to figure out what's going on in the hospital. And once you're able to hear the patients and the customers, you're able to figure out, therefore, what do you need to do to improve the process. So from this listening post are coming out small projects to do with discharge, conversions, OPD wait time, etc., which we are doing now. And what we have done is we picked up each project, and obviously first you pilot a project. You just don't launch it into, and sometimes what you think on paper is good, the ground reality turns out to be different. So we piloted these projects, we ran them in some floors of the units. And once they were successful is when we started training, skilling, changing process, technology, and then monitoring and reviewing. And some of the results I will show you of what happened in the last 6 to 9 months. And then you get into a culture of continuous improvement. You start skilling people. You encourage them to become change agents. They pick up small projects of their own. You start rewarding them. You start celebrating the early successes. And that's how this cycle continues, a virtuous cycle of improvement, sets in the organization. So I'm going to skip these 2 slides and go straight on to the 4 or 5 projects I want to talk about. The first one was on ER with the length of stay. And you'll be surprised that simple things like standardized templates of discharge based on symptoms, talking to clinicians of the conditions under which they will refer patients to triage, even synchronizing the clocks in ER, and some of you have handled medico-legal cases will understand the importance of this, right? was some of the improvements we were able to push through, and therefore the ALOS came down about 14%. Project Disha. So we noticed that about only 25% of our patients were able to get discharged, before 2 p.m. And therefore that's put pressure on admission and therefore patient experience. Therefore there's more chaos once the occupancy goes up. And we discovered there were 3 issues really coming in the way, and these were what we call as the holy cows. One was that the percentage of planned discharges were far less than what is supposed to be. Because each clinician said, I really can't plan, depends on the patient's condition in the morning, so I can't commit the evening before. Look at discharge summaries. So you start your rounds at 9 o'clock, you finish about 11:30, you go back to your desk, and then the summary gets written, then it comes to nursing station, so obviously you can't get discharged before 2:30, 3 or 4 p.m. And the third was the interdepartmental handoffs, return to pharmacy, billing discrepancies, etc. So all we did was looked at these pain points and said what we can do to change the process through use of skilling, technology, clarifying accountability. And for the last 6 months, we've been running this project in parts of Saket and other units. And now the discharge is that about 60% patients get discharged before 2 p.m. That's the result of this project. The third one we call iWish, because truly it's an iWish system. If you look at the experience of people in OPD, the biggest grouse that they have really is the wait time. The doctor comes late, they come and sit down over there, and they don't know when their turn is going to come. It's absolutely a black box. So here is a system which is under beta currently in one of the units, where we have said, imagine all patients book their appointment online, or they walk inside the lobby, there's a kiosk lying over there, they book the appointment, out comes a token number. The same token gets flashed in the doctor's consult chamber through a digital mechanism. You sit anywhere in the facility, you'll get a text on your mobile, or you can see a digital dashboard to see your turn has come. You walk inside doctor's chamber. If you're an old patient, your records are already available on the touch screen with the clinician. He or she consults with you and gives you an e-prescription, whether it's pathology, radiology, or pharmacy. You walk out to the pharmacy, your bag of medicine is ready, you pay the money, and out you go, right? End-to-end digital experience for the patient which deals with the pain points. Now it's under beta. We have had certain challenges which I will describe to you once I go to that slide as well. And we have seen in the last 6 to 9 months the delta impact on conversion revenue is about 1 crore a month in one of the units. So that's the impact of iWish. The next one is BCMA. This is barcoded medical administration. As you know, most of the errors between prescription, dispensing and administration that happens and hurts the patients. I know some hospitals are already doing it in India. So basically you have a barcode around the patient's wrist. Each time the clinician will prescribe a medicine, it goes to pharmacy through a digital entry. When it comes to the nursing station, the nurse will go inside to the patient, will scan what is on the wrist as a number, and as well as the barcode on the medicine. If the two match, the medicine gets administered. And through this, you can monitor time of medication, dosage, and the right medicine going to the right patient. So that's to do with BCMA. Now, as we implement all these changes, what is very critical is how does the organization, the people, the paramedics, the nursing, the clinicians embrace this change? As we heard the minister in the morning say, the paradigm shift has to be all pervasive. It can't be in one part of the organization. And when we went and spoke to the front office people, and the great insights come when you talk to people on the ground. Because really that's where the moments of truth are happening. And when we spoke to them and asked them what's coming in the way, you'll be surprised we found a list of 102 items coming in the way of service. From system downtime, to screens, to empowerment, to lack of skilling and training. So we picked up all those items and one by one dealing with them now. And that's what is called, Missions Pride, skilling and training the front office to give the right service to the customers. And the last one is about influencing change. It's a unique methodology called LSIP, Large Scale Interactive Process, wherein you invite the entire unit into a room for about 4 to 5 hours, align them to your vision, align them more importantly not to the what but to the why. As long as people understand the why of what you're asking them to do, they are able to participate in the change, and you find good ideas coming from them. So we did this exercise across all the units, took us about 2 to 3 months to cover everybody, and that's the benefit that we are seeing. These were some of the projects that we did. Of course, many challenges. So the clinician would say, I can't consult using an e-system with the patient, I lose eye contact. Right? I don't have drop-down screens. It takes me more time to consult with the patient. I can't plan discharges, etc., etc. So a lot of challenges came our way. High attrition, as you know, on the front office desk and on the nursing staff, and we have to overcome that as well. So challenges on process, on people, technology. but through very persistent and tenacious efforts, we've been able to find solutions to most of them. Here are some results which I already spoke about. So we do track our customer experience index, which is called the top 2 box rating, patients who are very satisfied or delighted. That's moved by about 40% in the past few months. Discharge I already talked about. And the patient experience in the front office scores have gone up by 50%. We reduced the ALOS in ER by 14.3% and a reduction in median ALOS as well by 14.28%. Our learnings and how you can do it: don't please attempt mega projects. They take 9 to 12 months, they always fail. Look at small projects which take about 3 months, 2 months, 6 months, 5 months, 4 months to do. Celebrate early successes. Involve the larger organization. You can't do change. We can do a pilot in a select part, but you can't do change across the organization unless you involve people. So please involve people, get the culture going, reward early successes, train them, skill them, enable them. Most of the time you'll find that the hesitation is not to do with will, it's to do with skill. So as long as they're enabled and they are skilled, the change will come through. So that's been our experience. Happy to answer any questions if you have. Thank you.
Thank you, Rajit, for multiple reasons, primary one being that you stuck to time. Ladies and gentlemen, you'll note that each of the speakers will have similar slides, and they will answer 6 questions. Like his slides showed, the first is how we did it. That is, how did the organization do it? The second, why did we do it? The third, what were the problems associated in doing it? Fourth, how were these problems solved? Fifth, what were the results? And fifth, what can you, the audience, learn from it all? So these 6 will be running themes right throughout in these presentations, just as you saw in Rajit. Rajit, thank you very much, so kind of you to be with us, and we look forward to having you in other programs of Ficci in the future. Now, introducing an engineer who did a lot of IT work, both here, South Africa, and the United States, and works now for Fortis Healthcare. Varun Sood, he's the CIO and head of the strategic initiatives. He's going to be talking about HR, supply chain, and finance through a project which Fortis did called F1. Varun Sood.
Thank you very much. Pleasure being here. I have been engaged with Ficci in multiple forums, but first time at the Ficci Heel. So today I'm going to talk to you about an initiative we took up about 16 months ago called Project F1, and what it means for us and why did we take it up. I think that's a very critical understanding. But before I get into that, just to step back, I think the challenges that we face as healthcare as a system, India, be it globally, are all the same, just the scale and complexity varies. I mean, the iron triangle of quality, of affordability, of access is true everywhere we go, be it India or overseas, and we're just trying to solve it in different ways. The bigger challenge we face as healthcare is that, no matter what we do right now, be it starting with policy changes to tackle some of the critical manpower needs that we have, or clinical talent needs, or financial capital needs to actually build more hospitals, these are all incremental. They will not help us solve healthcare's problem as we go along, because as we do solve these, the problems are only going to get compounded and grow up. So we do need to look at it in different ways. And from an India standpoint, and when we step back and looked at it, we've got a couple of very unique situations here. There's a problem of affordability as we see it. So while we are low cost as far as the world goes, within India, Indian healthcare is not very cheap. There's a problem of access, of about 65-70% of India not having access to healthcare per se directly. So how does a corporate go about and actually try address these problems is a view that we took when we started out, thinking about 2 years ago. One of the key things that came in was that while there is a lot of work to be done on the quality side, be it the clinical or customer experience, so those are parallel conversations that are ongoing and projects on in that, there is also a lot on the efficiency and productivity side that needs to be done. The challenge there being that from a Fortis standpoint, and I'm going to skip into it, that Fortis historically we have grown a lot through acquisition. So there's been a lot of greenfield activities and a lot of brownfield activities that we've done. We've also acquired a lot of processes, a lot of cultures, a lot of ways to do things. As a group of hospitals, we were operating very well, but as one company, there was a lot of efficiency and productivity we could unlock, which could then be plowed back into actually providing better care or reducing costs or being more effective on the delivery side for people. So we started an initiative called One Fortis about 2 years ago. One of the projects we took up under that was actually was to work towards getting one common way of understanding what our operations mean internally, one common way of operating at the back end, which would be HR, supply chain, finance. More importantly, one common way to look at our business. While a lot of organizations out there already have that in place, coming from where we were historically, this was a huge task in our organization. At that point in time, we were about 58, 60 odd hospitals, and we had to look at how do we do it across. Coming from a lot of acquisitions we had done were organizations much older than us. We had acquired the Escort system, which was actually 25 years old, but Fortis now is only 14. So there was a lot of legacy and history which came with it. And there were defined ways of doing it. So our objective with One Fortis that we set out 2 years ago was one, have a consistency of user experience, of customer experience, be it internal or external, and enhance it. We need to have one way that people experience us internally or externally. And I think the internal one is a key point, to what Rajat was saying as well, that how do your employees see you and experience you becomes a key aspect as well as you move forward. Business decision support systems from any business standpoint are very critical. And I think the critical part was unlocking efficiency and productivity. So out of this One Fortis, one of the initiatives we took up was actually to target most of these through a common integrated HIS and ERP backbone across the organization. We planned to do it in 18 months across 30 plus hospitals, units that we had. We've actually completed it in 16 months below budget, and we've actually met all the outcomes we targeted at the start point. It's been an interesting journey. It's been actually, typically when you talk technology, especially ERP or large initiatives, or even M&A for that matter, 50% of all such initiatives fail. And in an organization which had the complexity of processes and cultures that we had inherited and that we were operating in, this was a big deal. And we had to figure out how to get it right because we could not get it wrong. And it's been a success there. So how do we do it? I think the key part, and a lot of it will echo what was said earlier, is it became everyone's project. It's not mine or yours or the CEOs or the MDs or one facility heads. It's everyone's project. It becomes critical that everyone be part of it and own it. We had actually put the whole weight of the organization behind it. And I think the biggest contributor to success that has come out is that, for something which you believe is important for you, you have to put your best people on it. And this is a struggle that normally happens in every organization. As soon as you pull your best people out, operating teams on the ground are going to cry. Yeah. But if you really want to succeed as a company, you have to actually balance that out and pull in your best talent to actually make the impact that you need to make. And it's not an easy task to do. People only do things when they have a vested interest. I mean, that's a known thing. So how do you commit and ensure that people who contribute are actually going to grow? That was a key aspect we looked at before we started this initiative. We said whoever is contributing to this and becoming a part of it, we will ensure that their professional and personal growth is committed to by the organization. Involvement of people is the other very big factor. I mean, we are a large organization across India, or the length and breadth of India. We actually, go from the urban to the tier 2, tier 3 cities as well. We have multiple models of hospitals that we operate, from very large multi-speciality to very small super speciality facilities, and a lot of plays in the middle there, models in the middle. We had to make sure that everyone had bought in because all the operating models were different. How one facility, how an Fortis Escorts Heart Institute functions is different from how Fortis Vasant Kunj operates. A Fortis La Femme is a super specialty women's care facility, which is very different from how a Fortis Shalimar Bagh would be in a multidisciplinary aspect. More than that, we had cultural aspects as well. We had acquired the Wokhard system in the south, about 10 odd hospitals, different way of operating. The involvement of all teams of on-ground people in actually committing to and designing what they want to be as an organization was a critical aspect that went in there. I think the most important part that when we started out, we didn't start a project. We started out to meet outcomes, and we defined the outcomes right up front. These were quantitative, clearly defined, measurable outcomes. And that has been the key success parameter per se. Because as soon as you have an outcome, your conversation on problems is on solutions to target the outcomes and not on problems that you're facing, because you fix a North Star on what is it that you're looking to achieve. And the frill, the conversations around it on problems actually then kind of dies away with everyone focusing on outcomes and more outcomes per se. Now, we had a lot of problems. I mean, it's nothing of what we did that anyone does it without problems. I think one is, everyone has a way of operating. And especially in our scenario, with the history of the organizations that we'd acquired, the hospitals we acquired, there were established methods of operating, the holy cows of business, if you were to call it that way. There was a lot of variation in how we did things across the enterprise, from hospital to hospital. Because of where we were again, there was a lot of perception of loss of control, and that carrying people along with you became a big issue. I think the more important part is, we are a young organization. We as a company are aggressive, we are dynamic, and we do a lot of new things, and we're trying them all the time. There is always a chance of change fatigue which sets in, which is a big bottleneck to any change that happens. You get tired. People get tired by the end of it, because at the end of the day, it's a set of people who have to actually end up doing multiple things, be it deliver operations on the ground or run corporate or anything in the middle there. Change fatigue is an important thing that we actually hit in the middle, and we had to continuously look out for as well to make sure that we were not overdoing what we did, so that the adoption of change for it to become effective became a critical factor. So some results. So for a change, in our history now, we actually have always-on dashboards with real-time analytics in a multitude of areas. And these don't just cover finance, HR, supply chain. They also cover analytics on procedures done, on clinical outcomes that are being met, and on many fold activities that are coming up now. Not all of them are live. They will be going live over a period of time. We have now a platform to have on-the-fly analytics across multitude of aspects across the business. It's all about the quality of data that comes in, and we've worked very hard to try to get it in. And it's something that we're working towards actually further enhancing. We do have fully integrated and common processes across the enterprise. This has actually led to, in some ways, employee productivity. Our ability to port employees or a resource from location A to location B and make them productive in the least amount of time has actually been achieved here. That was one of the outcomes we had targeted. There's high attrition in India, and this is the key aspect which comes into play. Can you move a nurse from location A to location B? Earlier, there were problems because the systems were different, the processes were different. Now it is seamless as far as the move goes. We have a common way of actually looking at our business now, which actually comes from the quality of data that you get into it. A lot of times, from an operating standpoint, this is trivialized, but actually from an organization standpoint, what you have in your data is who you are, and your ability to churn it, turn it around, and analyze it is critical for reacting faster and being proactive in decision making. The other big one is that now we do have just one way that every Fortisian is looked at. The rules are same, the policies are same, the processes are same. Again, this is easier said than done, because it also involves things like, under the garb of an ERP implementation, a lot of it can get lost, but critical things like even leave standardization or policy of leave standardization between Bangalore and Bombay and Delhi is a big deal, especially if you have established systems working in play there. So I think the biggest thing here, again, echoing what was said earlier, I think the biggest thing here is you have to know why you're doing it. And that why has to be understood by people. Because if people don't understand the why, they're never going to fully align or own or work towards what you need to do. It just becomes a project. For effective change to happen, you have to actually connect at an emotive level where people have to understand the impact of what you're doing and why it is critical that the organization or they themselves need that. I couldn't overemphasize the objectives of having real, measurable, clearly articulated outcomes which everyone understands, and there are no debates or deviations around the definition of that outcome. This is the one rallying call around which everyone can then work. It becomes the North Star, the center post, where you can actually say, this is the only way we look at a business or the outcomes here, and let's all work towards that. From an engagement standpoint, it's very critical to have a mindset of actually not finding problems and just going into a negative spiral there, but actually saying, look, problems will happen. And every project, be it a technology project, a clinical outcomes project, or any initiative, whenever a problem hits, what do you do? How do you react to the problem becomes a critical one. Do you find ways to actually find solutions, or do we find ways to only raise problems and make it worse? Okay. We all partner with people. No one does it by themselves or can do it all alone by itself now. It is very important to find the right cultural fit as far as a partner goes. A lot of times we go for the brands, the big names, or the smaller ones, and it can become a cost and quality question which comes into play there. But I think the one factor that we all leave out at times is actually saying, can the organization that we partner with work with us, fit culturally? Can we work with them? Can they work with us? Because you want your partner to be your team, and vice versa. And it needs to be one happy, big family working together, committed to the same outcomes. And in that model, the way the partner operates culturally is very important. I couldn't overemphasize the importance of having the right team, incentivized the right way, and motivated the right way, and the importance of having the management of the company, the organization actually make sure that what they do and what they commit is delivered, and that they do take care of the team. Because these teams go to high pressure, they go through a lot of issues while they're delivering, there's a lot of resistance that comes up, and how an organization supports it and stands behind them during the change is what is very critical to as we move forward. So, those are the aspects I wanted to cover. Thank you very much. Happy to take questions.
Thank you, Varun. This is the first time I've heard a project leader talk about one aspect. That was line 3 of his How We Did It, that the best people were chosen. Is that the reason why you were chosen to lead? So you are patting yourself on the back. But a good job done, and thank you. Of course, we will all stick to 15-minute schedule, so plenty of time for you to ask questions at the end. I'm now going to request Professor Anupam Sibbal, the Group Medical Director of Apollo Hospital Group. I had heard him speak on this particular subject at least on 2 or 3 occasions, and every time I was enamored. Not just because I'm a clinician, but I think this is why we do healthcare delivery, and that is excellence in clinical delivery systems. But how do we measure it? Apollo has a system called ACE25, and Anupam will lead you through it. He's a pediatric gastroenterologist and hepatologist. He was involved with the first successful liver transplant that was done in a pediatric age group in India. And he's the honorary clinical professor at Macquarie University, Sydney, since May 2015. When I last talked to him, he was involved with a university in Brisbane. So he's moving, getting more urbanized. Over to you, Anupam.
Good afternoon, everyone. It's indeed a privilege to be back here in this wonderful auditorium. Thank you very much, Shobha, the wonderful Ficci Health Services team, and Dr. Puri for this kind invitation. It's been a delight listening to my co-panelists, and I look forward to the other 2 panelists. One simple question, how we did it. To answer that one simple question, I'm going to ask everyone one simple question. Is there anyone in this hall who is excited about going into hospital as a patient? Anyone? Not even one person who gets up in the morning and says, yippee, it's my lucky day, I'm going to undergo a colonoscopy today. No one? Why is that?
If I'm doing it, then
Why is that? That's because we're worried about pain, we're worried about discomfort, but more importantly, we're worried about outcomes. So what do we want as patients? Well, we want excellent clinical outcomes. We clearly want value for money if you're paying for it, and that's the vast majority of Indians. And of course, I want good service. What does a physician want? What does a surgeon want? They want clinical excellence. They want good results. They want excellent outcomes. They want the patient to go out and tell the whole world, I had a wow experience. This doctor is just so wonderful. And of course, they want an atmosphere, a milieu which is conducive for them to do what they really like doing. That is clinical work, which is really stress-free. For those who are interested in academics and research, they really want an environment that supports that. What do the health insurance companies want? They want excellent outcomes. They want people to get out of the hospital as soon as possible. They want decreased average length of stay so that they don't have to pay as much to the hospitals, and that they don't have to increase the premium, and if they don't increase the premium, then they will retain clients. So what is the common thread between patients, between doctors, between insurance, and it's actually clinical outcomes. So that's the reason why we undertook this project. So what exactly did we do? We created a balanced scorecard. It's a clinical scorecard. It's called ACE at 25, which is Apollo Clinical Excellence at 25. It was also 25 years of Apollo's existence that we launched it, and we decided to choose 25 parameters. So we did an extensive review of literature, looked at the best published outcomes from across the world in procedures, in surgeries, and other parameters that were of interest to us. We reviewed this data, put it all on the Apollo Lighthouse platform so that we were able to look at it live. And when we were doing the study on benchmarks, we really looked at hospitals across the world and found that at best, even the top hospitals could able to contribute 1 or 2 or 3 parameters. So we looked at Cleveland, Mayo, we looked at Mass General, we looked at Columbia, and a variety of other institutions and databases. So just to walk you through a couple of these. So the best bypass surgery results in the world are from Cleveland, and 99.4% of their patients go home. So the mortality rate is 0.6%. So we decided to apply this and created a benchmark saying that if any hospital undertakes a CABG procedure, it doesn't matter how big that hospital is, it doesn't matter where that hospital is, but if it's going to do CABG, then the benchmark is Cleveland. So if you have a survival figure of 99.2%, you get a score of 4 on 4. But if it drops down to more than 2%, you get a score of 0. Now let me confess here that most hospitals in the world would be delighted with an outcome of 97.9%, and it would be really good. But in our system, you'd get a score of 0. Liver transplants. Most hospitals would be very happy to actually have a liver transplant program. But if you're going to do a liver transplant, and we do this at a few locations within our system, well, then the survival figures have to be comparable to the best in the world. And for liver transplantation, it's Mayo, which is the second busiest solid organ transplant program. We are the world's busiest solid organ transplant program now. But we benchmark with them because they've been in the business longer than we have. And their survival figures are 93.1%. So if you're comparable to Mayo, you get a score of 4 and 4, but if it goes down, your score goes down. Catheter-related bloodstream infection. So we looked at the NHSN network, and the NHSN benchmark changes over a period of time, and this is what the current one is. It's 2.79. So if our hospitals are there, they get a score of 5. Well, if the score doesn't match up with NHSN, their score decreases. So what we get at the end of each month is a score which is capped at 100. So every parameter has a score of 0 to 5 or 0 to 4, and when you add up these 25, you get a score of 100. So if a hospital is more than 75, they are in the green zone. 50 to 75 would be yellow, and less than 50 is red. And I have to say that being in a score of more than 75 month on month is not easy, because remember, these are not just any outcomes, they are the world's best published outcomes. So for a hospital to be in the green zone isn't easy. So this is what we get at the end of each month, and this is data from some of our major hospitals. And so we had some amazing scores from a particular hospital. We had scores that vary. We have hospitals that go into the yellow zone, then become green, then again become yellow. And this is data from one of our hospitals across all 25. So we get this at the end of each month. We created the Apollo Clinical Audit Team because we were relying so much on data. So the idea was to standardize the methodology of data collection, how to validate the data, train the auditors, give them an audit guide, and then send them out into the field, do an interim audit, and then do an annual audit. So each institution has 2 audits where we check in the raw data and compare with what was fed online. So how we did it? Well, it was tough. It was definitely not easy, and for a variety of reasons. We started off, of course, with 6 locations and thought that once it's stable, we'll take it to 25, and then we took it to 32 and 42 finally. We made sure that the group leadership reviewed it every month. We started looking at the quarterly action taken reports that now go to the board. We linked the medical head and the CEO's appraisal to clinical outcomes, and that's quite novel in many ways. We started giving out the ACE award, so whoever had the best scores for a year got a nice award, and there was a cash component to it. And to keep it exciting, because if a hospital is doing really well and the scores are really always in the green zone and they are getting progressively better, then you tend to get casual about it. So we've been revising the parameters and have, over a period of time, made them harder or done away with some parameters where we've scored consistently at 100%. So every 2 years or so, we change the parameters, and recently on 1st of April, we brought in a newer version. So problems, well, all of our hospitals are diamonds, aren't they? They're really precious, but there is a huge variation in terms of size. We have hospitals that are 50 beds and we have hospitals that are 700 beds. So when you are looking at a diverse group of hospitals, there are going to be variations in terms of how you work with the teams and how do you actually get everyone to get onto the same page. And diamonds they are, but they are very distinctive. We have hospitals that are in rural areas. So Aragonda is a village. We have a hospital in Bilaspur where the closest airport is 4 hours away. We have hospitals in areas where there are Naxalites and then there is civil unrest. And we have hospitals in the big metros. So there are lots of variations. So to get everybody onto the same page was a big challenge. So what were our results? What were the learnings? Just sharing data with you from some of our hospitals for certain specific parameters. For example, average length of stay post angioplasty. So remember here that the score we are looking at is 4. So the hospital did in 2 months 3, then they got to 4, then it decreased again. So there will be variations depending on the complexity of work, but you constantly have to be at it. Catheter-related bloodstream infection, we thought we'd got better, then we had a dip. There was a change in how we were managing these patients. We followed them up in terms of the change of protocols, and then we had success. Urea reduction ratio in patients on hemodialysis, we really dialyze a lot of patients. So what is it that we can do to optimize the outcomes from every single dialysis encounter? So initially, the scores weren't really good, became better, and have stayed so. Average length of stay post TKR, we thought we got it right, and then we had a dip, and we really had to look at pain management and look at some of the other protocols, and then consistently they've been good. Complication rate post-coronary intervention, again, there will be complications, so you have to constantly monitor and have to look at what you've gained from every mistake so that it doesn't get repeated if it was a mistake or if it was a preventable complication. And overall, if we look at the ACE 25 scores across the group, so we were at 70 when we started off, and the score has consistently become better over the years. How everyone can do it? Well, I'm a pediatrician, so I had to bring a child in. It actually is a child's play once you actually set your mind to it. It's very simple. You have to decide whether you want to do this, and if you want to do this, then you choose appropriate indicators based on your volumes, complexity of cases, the kind of work that you do. Then you look at benchmarks, and an extensive review of literature would help in that. And you start looking at goals. Who do you want to compete with in terms of outcomes? Then start looking at an implementation strategy, start with a pilot and take that pilot from perhaps 1 hospital to 3 and then build it if you have a large group across the group. Extremely important to monitor not just the implementation but then monitor results. Extremely important to have an audit mechanism in place that allows you to catch something if it isn't the way it should be. And it's really about learning from each other. We were surprised that some of the solutions really came not from the biggest or the so-called best hospitals, but were from small hospitals where the close-knit teams actually came out with solutions which we could take beyond their hospital to other hospitals and actually to the group. So it really was about learning and teaching, because it's really together that you can cross greater heights. Thank you very much.
Thank you, Anupam. So, ladies and gentlemen, you heard from Mr. Mehta something about listening from the patient and improving service delivery. You heard from Mr. Varun Sood about business and how we can do a better business and amalgamate a very varied business. From Dr. Sibal, you've just learned how you can do well by following the basic principle of measuring what you do and having a balanced scorecard as far as clinical conditions are concerned. But now the person whom you're going to hear is very different from these big three of healthcare delivery, Max, Fortis, and Apollo. He is, as I jokingly was telling him at lunch, the Uber or the Ola of healthcare. He's a healthcare facilitator who provides something that very few in India have attempted, and that is focus on preventive and diagnostic. So preventing disease rather than what these three majorly do, and that is treating disease. Please welcome Mr. Harish Pillai, also an engineer and also a management graduate who has worked in Africa. He's worked in several group companies with great names like SL, Mahindra & Mahindra and Alpha Level. He's the CEO of Indus Health Plus. They started in Maharashtra, but they're spreading very fast. They provide healthcare solutions to the average person by having preventive health packages delivered not by them, but through different hospitals, such as these three big hospitals who are also sometimes part of their network. It's a very intriguing model that they've got and something that we can all learn from. Over to you, Harish.
Thank you, Dr. Puri. And it's not only the three people on the dais who are our partners. There are several of them sitting in this room who are our partners, and a big round of applause to all of them, because without them, we wouldn't have been doing anything what we are doing right now. It's only thanks to y'all. It's only thanks to y'all. You know, and it's a great privilege that Ficci Health Services Committee, Dr. Puri, and all our well-wishers gave us the opportunity to talk about this, because preventive healthcare is, you know, actually the flavor of actually the year. In fact, even Prime Minister Modi, you know, he summoned it in his speeches, and even the Finance Minister mentioned preventive healthcare, but didn't do anything much about it, right? So, is preventive healthcare important? Given the state of India's situation, very, very important. Okay. So before I start, why we did it, I want to take you all through a small video, which we did with the famous Mumbai Dabbawalas. All of you have heard of the Mumbai Dabbawalas here? I'm sure a lot of you must have heard. For those who didn't know, the Mumbai Dabbawalas are setting world-class benchmarks as far as quality and delivery goes. Okay, so a group of around 30,000 people deliver over 2 lakh dabbas per day. Okay, come rain, come even on the days where you know, the bomb blast took place, they still delivered dabbas on time. Okay, so with that kind of consistency, we did something with those interesting people, and I would just like you all to, just a 2-minute video, so I would just like you all to, you know, just listen to this news item which had come. This is one of the reasons why we did this. I hope the volume is there.
वहीं आज मुंबई में डब्बे वाले सड़कों पर उतर आए। विश्व कैंसर दिवस के मौके पर डब्बे वालों ने लोगों में कैंसर के प्रति जागरूकता फैलाने का काम किया। पेश है एक रिपोर्ट। दुनिया भर में अपने काम के लिए मशहूर मुंबई के डिब्बे वालों ने वर्ल्ड कैंसर डे के मौके पर कैंसर के प्रति जागरूकता फैलाने का काम किया। दरअसल करीब 2 लाख मुंबईकरों को रोजाना गर्मा गर्म खाना पहुंचाने वालों को कैंसर अवेयरनेस प्रोग्राम के लिए खास तौर पर चुना गया है। इस नेक काम के लिए डिब्बे वालों का जोश देखते बन रहा है। गुटखा हो, सिगरेट हो, तंबाकू हो, ऐसे खाने से आदमी की हेल्थ खराब हो जाती है। इसलिए शाम को डब्बा देने का काम पूरे बम्बई में कर रहे। हर घर में, हर इंस्टीट्यूट में, हर प्लेटफॉर्म पे, हर गली से साइकिल लेके दौड़ते, कंधे पे लेके डब्बा दौड़ते, सर पे लेके दौड़ते, हर बिल्डिंग में जाते हैं, हर ऑफिस में जाते हैं, और डब्बे के साथ साथ टी शर्ट भी पहन के हम दौड़ेंगे तो हर रेलवे के प्लेटफॉर्म पे, हर गली में, रास्ते में हम सब पब्लिक को संदेश देना चाहते हैं कि पब्लिक ने अपने हेल्थ के लिए अपनी केयर रखना चाहिए, तो लाइफ ज़्यादा अच्छी, ज़्यादा जिंदगी जी पाएंगे। ये हकीकत है कि कैंसर एक घातक और जानलेवा बीमारी है, पर यह भी सच है कि वक्त पर बीमारी का पता चलने पर कैंसर से बचा जा सकता है। आखिर कैसे और कब जांच करवाया जाए, ये जानकारी आम लोगों के पास कम होती है। इस तरह के जागरूकता कार्यक्रम से लोगों तक सही जानकारी पहुंचाई जा सकती है। कैंसर बहुत फियर के साथ जुड़ा हुआ है, लेकिन उसके बारे में कि सच्चाई लोगों तक पहुंचनी चाहिए। कैसे हम उसको अवॉइड कर सकते हैं, कैसे हम उसको डिटेक्ट कर सकते हैं पहले स्टेज में, क्योंकि अगर पहले स्टेज में प्रिवेंशन की वजह से उसको अगर हम डिटेक्ट कर सके तो लाइफ एक्सपेक्टेंसी भी काफ़ी बढ़ सकती है और कॉस्ट ऑफ ट्रीटमेंट भी कम हो सकती है। भले ही इन डिब्बे वालों को मेडिकल टर्म्स के बारे में ज़्यादा जानकारी न हो, लेकिन ये जानते हैं कि जिंदगी अमूल्य होती है, और अगर उनकी इस छोटी सी कोशिश से किसी की जिंदगी बच सकती है तो ये उनके लिए खुशी की बात होगी। प्रियंका कांडपाल के साथ रंजीत कुमार, जिया न्यूज़, मुंबई। तो कैंसर की इस लड़ाई में लड़ने के लिए मुंबई की सड़कों पर अब डब्बे वाले भी उतर आए हैं, लोगों में जागरूकता का संदेश दे रहे हैं। फिलहाल ले रहे हैं एक छोटा सा।
Okay, so the reason why we worked with the Mumbai Dabbawalas, more than 25% of them are suffering from tobacco-related elements. Okay, so this was a starting point. Many of them became our volunteers. They went out, as you saw, that was just a specific occasion which they did on February 4th. But it's not just February 4th, it's what they do year on, all throughout the year. That's the one thing which really counts. Okay? 1 in 4 Indians is a cardiac patient or a potential cardiac victim. I mean, we keep arguing with cardiologists who say that not 1 in 4, 4 out of 5, right? If we don't get into the semantics of it, 1 in 4 is a pretty high number. 1 in 10 is a diabetic. And if cardiac and diabetes are correlated, then the percentage of risk of that person getting a heart attack is that much more higher. We are fighting with China, and it's not a very happy fight to have on being the diabetes capital of the world, right? So some figures say 220 million, some figures say 230 million. It's just semantics, because if 1 in 10 is a diabetic, and when we work across states in this country, we are shocked at what the statistics reveal, okay? Chairman of Apollo, Dr. Pratap Reddy, being a big fan of our program, he argues with us consistently that in Tirunelveli, the positives which arise out of, when we screen people, it's something as high as 31%. I mean, we don't want to believe these kind of figures, but this is ground reality, right? So if these are the challenges, what happened to enable one company sitting off in Pune to start off on a mission of prevention, okay? Let's put it this way. In 2000, some of our founders are sitting there, and they were all in their early 20s. So when you're in your early 20s, it's okay to fail. It's okay to go into areas where nobody has gone before, because you're not driven by any past baggage. You're not driven by any of the, preconceived notions. So when the team went out, okay, one more reason. One of the founders lost her father due to cancer, okay, and that 1.5 year period, where they suffered not only financially, but also the fact that they lost the person motivated them to start the company. Apollo is the founding, officially in India, founder of preventive healthcare. 1980, Dr. Pratap Reddy started the program, right? But today we work with not only Apollo, but we work with Fortis, we work with all diagnostic centers. As I said, many of the people are there in this room. I can't name all of them, because if I take somebody's name and I miss somebody else, they will not feel nice about it. But every one of them have contributed in making our model a success. So what is the first reason? First reason was only intention. We wanted to keep people healthy. Dr. Anupam said, how many of you would like to go to a hospital? You get up in the morning and say you'd like to go to a hospital. In our case, certainly, with all the effort which we put in, the person would love to go to a hospital for a checkup or a diagnostic center for a checkup. Okay, so that's the effort which is required to convert a mindset. Okay, 80% of India's population goes to private healthcare. This I'm sure everybody in this room knows, right? So if to give mathematical figures, if around 800 million of India's population is going to around, as per last IRDA report, 30,000 odd hospitals, which includes government and private put together, the number for beds versus patients, or the hospitals and diagnostic centers together catering to this huge population, is absolutely skewed to only one side. Okay, so it is the imperative need for everybody to focus on keeping people healthy. Okay, so with hospitals very busy in curative, I should not use the word very busy. I think they have their own problems and they have their own challenges. So if hospitals are very busy doing that, then somebody has to take the baton and somebody has to push on and move this agenda of prevention. Okay, so when I talk about these statistics, I already told you about cardiac diabetes and cancer. Our programs essentially focus on NCD, cardiac diabetes and cancer. Okay, more than 52 lakh lives were lost last year. This is not our figures; this is WHO figures. Okay, and look at the economic impact. Okay, if we are talking about India, like just last week we had the Great China meltdown, and everybody was praising the Indian economic model. But if a large percentage of our population is going to suffer from cardiac diabetes and cancer, then what economic model are we talking about? So one is to look at everybody as a collaborator and not as a competitor. It was very hard. Initially, hospitals would ask, why are you wanting to do this. We are also doing this. But if you actually look at it, if a hospital or a diagnostic center, the geographic radius which they would reach out to would be maximum a few kilometers. Yes, some of the more adventurous hospitals and the more ambitious hospitals with little more larger marketing teams would reach out to some more cities. But how do you reach out to Tier 2 and Tier 3 India? How do you reach out to the villages? How do you reach out to more than 80 kilometers and 150 kilometer distance? And how do you make a person voluntarily come in for a preventive health checkup? And our experience has been that Tier 2, Tier 3 India and the villages adopt preventive healthcare much more better than metro cities. Maybe because metro cities people feel that they have a choice. Okay, but this has been our experience. If you look at how did we do things differently, one was getting the hospitals and diagnostic centers to agree. Second is, like we don't like to say this, but to work at prices which are, I should not use the right words here, so let's leave it at that, at those kind of prices. Okay, and then the speed. If you want to do large volumes, then you have to be doing very fast turnarounds. So how did we implement the fast turnaround? By having our own desk. The hospitals and diagnostic centers were very kind enough to give a desk in the, in their various hospitals. We added a little bit of manpower, and when we modified some of the process flows to ensure that you got reports the same day. Getting reports the same day anywhere in this country or across the world is a huge challenge, particularly when you're combining lab, radiology, medical consulting, all put together. So today, from Pune city, starting off with 8 volunteers and 5 employees, today we have 400 plus employees and more than 65 cities and more than 115 hospitals and diagnostic centers as our partners. The hospitals and diagnostic centers took us along. So when we started with just quoting Apollo, because they are on the stage here with us, even Fortis have taken us to different places. So when we started with Ahmedabad, then when the program rolled off, then they took us to Hyderabad, they took us to Hyderguda. Today we are even working in a place like Vizag. Okay, so that's how most of the partners took us along. So most important, nobody is a competitor. The huge NCD statistics which is there in this country, there's enough work, enough and more work for everybody. All of us put together, Indus has more than 5,20,000 retail clients. But and you take an Apollo which has something like 8 lakh odd, if you put all the pre-employment checkups, you put all the corporate checkups which is done, you put every diagnostic lab and every body in the country doing some form of preventive health checkup, you put all those numbers, it only reaches out to something like 60 million, and that's nothing. Okay, that's nothing compared to the population of our country. Most important, like I shared with you, 54%. Where is preventive healthcare being? This is even a shock to us. Preventive healthcare is being adopted more by rural India and semi-urban, the so-called semi-urban India, right? What are the challenges? As I shared with you, hospitals were focused more on the curative services, obviously given the gap between curative and the patient versus beds ratio. Then how did we combine? I shared with you how we combined the strengths of hospital and diagnostic center. I would like to share a particular example of a place called Surat, where in Meeta's Adventist Hospital, which is a Christian missionary hospital, so it's a charitable trust hospital, the cardiac is being done by Wokhart, okay, and the diagnostic is done by SRL. Okay, so it's a combination of all three, and together we are giving a patient experience which is a combination of all three. So all are competing with each other, but at the same time, we're integrating all the three to deliver a holistic checkup package. We did something called Senior Citizen Discount Program, okay, which was a very interesting thing. Now, senior citizens need preventive health checkups almost annually. Anybody above 60, 65, definitely, the logic goes that they would be needing. But the funny part, a lot of they are more concerned about their curative expenses. So they are dependent on their pensions, they are dependent on their children. So we realized very early that if we just focus on them, we are not going to get them to proactively come for preventive health checkup. So what did we do? We focused on the caregiver. We focused on their children. We focused on people who take care of them, and that's how we pushed a senior citizen discount coupon program, which we give almost like a CSR initiative at no profit, no loss basis. That program last year had around 45,000 people availing that. And the only reason it happened was because we did not focus on the target group, that is the senior citizen, but we focused on the caregivers, the children and the people looking after senior citizen who pushed them to take a checkup. Is the model virtually unknown? Yes, we're sharing it out here in the platform, the model virtually unknown. What is the good part about it? The good part about it is we are getting into places like GCC. We're getting into Dubai because more people die of cardiac disease in Dubai as compared to road traffic accidents. And this is a Google fact. So if this is the condition in a so-called developed nation like UAE, the situation in America is also not that far behind. So not only developed, but developing nations also are looking at our model and are encouraging us to come. So we invite all our hospital partner, all our diagnostic centers, we invite all the students here, anybody and anybody who wants to be a part of mission prevention, please come and talk to us. Thank you very much.
Thank you, Harish. That was indeed innovation. Could have also fitted in our last session, which is built for tomorrow. Don't miss that. You're going to have some people who even were rewarded by MIT who will be presenting some really innovative solutions to healthcare, but that's tomorrow.